Well, welcome everybody to today's webinar, Malaria, a clinical and diagnostic discussion. I'm really delighted to be able to welcome Drs. Daly and Turbot. Dr. Daly trained as an infectious disease physician here in Boston, where she practiced at Brigham and Women's and was an assistant professor at Harvard Medical School. She's now a professor of medicine and of microbiology and immunology at the Albert Einstein College of Medicine. Her research lab carries out field-based translational studies in Africa on cohorts infected with malaria and uses those data to define the molecular mechanisms that underlie variation in disease outcomes. So we're very grateful to welcome her. Dr. Turbot trained here at MGH in internal medicine, where she was chief resident, as well as in infectious diseases and in clinical microbiology. She's currently an infectious disease attending here at MGH and associate director of our microbiology lab. And she has a passion for improving the availability of malaria testing. So again, welcome. We're really excited to learn from both of you today. I'll read this disclosure. The content provided in this webinar is presented by the individual speakers only and does not reflect the official policy or position of any portion of the government. And it's not a substitute for medical professional advice, diagnosis, or treatment. This is, again, who you will see here today. And our learning objectives are to identify the clinical presentation of and epidemiologic risk factors for malaria infection. You'll also understand the diagnostic tools available to diagnose malaria and best practices for implementation. You'll also leave being able to recognize severe malaria and understand the treatment guidelines for severe disease. And you'll also be able to detect malaria in non-travelers, so locally transmitted malaria. All right.
All right, Dr. Turbot, we'll hand it over to you.
Great. Well, I'll go ahead and kick off the program. Thank you very much, Jake, and thanks to the organizers. Sarah and I have had a good time putting this together for you. So let's start with the case. This is a 44-year-old female who presents with fatigue, chills, anorexia, subjective fevers for 4 to 5 days, born in Guinea and migrated to the United States 10 years ago. And she reports that she had traveled to Guinea for 1 month, and 5 days upon return, she developed these symptoms, and she denies taking any prophylaxis for malaria. Next slide. So we'll start off with her exam and laboratory values. Blood pressure is stable. Heart rate is tachycardic. She has a moderate, actually she has a normal temperature. She's saturating well, and a completely non-focal exam. Her labs, she has a bit of AKI. White count is slightly elevated. She's anemic with thrombocytopenia, and rings are seen on the blood smear. So I don't know if we can talk to each other, but if other people have ideas besides malaria, put it in the chat, or Jake can tell us what we're seeing. But as we're waiting for that, I mean, things that we're thinking about, of course, are just regular bacteremia, viral illnesses, other things, UTIs. But certainly malaria is first and foremost. And I think, Sarah, if we go back one slide, a couple things in the history. This is the problem with malaria. It's completely non-specific. And we actually reviewed cases in the Bronx. 43% of children were sent home with malaria because they had GI symptoms, non-specific symptoms. So unfortunately, there's no smoking gun clinical manifestations. And the same thing with the laboratory values. Nothing here really points to malaria except the anemia and the thrombocytopenia. I have yet to see a case of clinical malaria where there's not thrombocytopenia. So this is a problem, and we need to make a diagnosis. We cannot make a clinical diagnosis. We need the laboratory, and Sarah will take it from there.
All right, so I will be going through how malaria is diagnosed. And as Dr. Daly has kind of mentioned, malaria really is a medical emergency. So delays in diagnosis can result in significant morbidity and mortality. And so having a clinical suspicion is really key. And as Dr. Daly just mentioned, the symptoms really can be nonspecific. And so anytime you have fever in a returning traveler, this should raise your suspicion. And so you do need to take a detailed travel history so that we can narrow in to determine if malaria is a concern. And so the things that you should be focusing on are the regions of travel, so the geographic regions, and then also the time that has elapsed between travel and return to the US. And the reason for that is that by having that information, we can start to understand what malaria species we might be concerned about. So this is actually a table from a review that's excellent from Dr. Daly in JAMA that looks at the characteristics of malaria species infections. And you can see the 5 species of malaria that can cause infection are present, and it goes through their geographic distribution, as well as the time between their travel and then their arrival back to the United States. And although you can see that there is some overlap, there also are some distinguishing features that can help point us in the right direction. So for example, for Plasmodium falciparum infection, which is the one that I think we all get most concerned about because of its severity, you can see that 90% of these infections are acquired in sub-Saharan Africa, and more than 95% of travelers will have infection within 1 month of return. This is in contrast to Plasmodium vivax, which is another common malaria infection that we see in returning travelers, where 70% of infections are acquired in Asia and Latin America, and only 60% of travelers will have infection within 1 month of return. So again, knowing this information can be useful. That said, clinical presentation and travel history is not enough to make the diagnosis of malaria, and so you need laboratory methods. And there are 3 common methods that are used in clinical laboratories: blood smear microscopy, rapid malaria antigen detection, and then nucleic acid detection. And we'll go through blood smear microscopy first, because this really still remains the gold standard for the diagnosis of malaria. And so a blood smear is essentially where we're trying to directly visualize the blood parasites on a smear in blood. For Plasmodium species, we're predominantly going to be looking at red blood cells. I will say, though, that there are other intraerythrocytic parasites, such as Babesia, and in New England, we actually see this more commonly than we do malaria. And then there are other organisms as well that can show up on a blood smear. But for the purposes of this talk, we're really going to focus on the intraerythrocytic parasites, Plasmodium most specifically. So what is a blood smear? Well, it's made up of 2 things. There is the thin blood smear that you can see here on the left, the thick smear on the right. And it really is best to have both, because there are advantages and limitations to each. And I'll go through those in more detail. So the thick smear is made by taking 1 to 2 drops of blood. You add some hypotonic solution, which results in lysis of the red blood cells. And the reason why that is important is that by lysing that blood, we're allowed to just look at a lot of blood. So 20 to 30 layers of blood can be viewed, which really enhances our sensitivity for detecting parasites if they're present. So this is really an excellent screening, highly sensitive method for the detection of parasites. It is then air dried, and then a Giemsa stain is performed, which is really a stain that just helps us to highlight the parasites if they are present in the blood. The main advantages of the thick smear is that it is highly sensitive. So this can detect incredibly low levels of parasitemia, which is really important. It can also detect all parasite stages in their life cycle, so that can be helpful. I think the main limitations here, though, is that it's not the best test to look at parasite morphology. And the reason for that is when we lyse the red blood cells, the parasites, their morphology can also get kind of skewed. And so as a result, if you're going to look at the morphology to try to determine what species of Plasmodium is present, this can be challenging with a thick film. Additionally, this is not a great test to look for the degree of parasitemia, which Dr. Daly will talk about is important when we think about disease severity, treatment, et cetera. And then interpreting this does require expertise. Looking at the presence of parasites versus artifact does require a lot of expertise. So moving on to the thin film, which is here on the left. So this is actually made in the same way that a hematology film is made, where you just take a drop of blood and you spray it across, you kind of slide it across the slide with the intent of creating this feathered edge here. what you're trying to then do is air drying the slide. And then this slide actually undergoes methanol fixation. And this is really important because that methanol fixation allows for us to maintain the morphology and architecture of the red blood cells and the parasites. So you can see this is an insert of what a thin smear would look like. And you can see, we can see the red blood cell beautifully. And we can also see these abnormal looking things in the red blood cells, which are intraerythrocytic parasites. These happen to be trophozoites associated with Plasmodium falciparum. And so this is useful for a lot of reasons. And so the big advantages of the thin smear is that it is a sensitive method. Because we are able to maintain that morphology of the parasite, we can get clues as to what species might be infecting the red blood cells, and this can be really helpful. Additionally, we can also quantify the degree of parasitemia, which can help provide some clues into disease severity and management, although it's not all of the picture. I think the main limitations is that this isn't as sensitive as a thick smear, and in order to interpret this, you do need to have expertise. So can the thin smear be used to determine species identification? Can we distinguish among all of the different Plasmodium species by looking at the thin smear? And I think the answer is that yes, for the most part, although sometimes it can be challenging. And the things that a laboratory technologist would look for are the size and shape of the red blood cells, as well as the parasite morphology. And in particular, they're looking to see if there are different stages of the parasite life cycle within the red blood cell, because that can be telling in terms of what species of Plasmodium is present. And so, for example, with Plasmodium falciparum, the red blood cells are often of normal size and shape. And then when we think about the parasite itself, we really only see early trophozoite or gametocyte forms in this illness. If you do see other parasite stages, this often reflects really overwhelming infection, and these patients are terribly, terribly ill. This is in contrast to the other forms of malaria, where you can see that sometimes the red blood cells can be enlarged, sometimes they're normal. And then you often see all stages of the parasite life cycle in these infections on the red blood smear. And so this is helpful in determining what species might be present. You can imagine, though, that this is challenging, particularly if there is low levels of parasitemia, because you just don't have enough parasite morphology to really look at. Additionally, some of these organisms will have similar morphology. So Plasmodium vivax and Plasmodium ovale can look very similar on blood smear, and so it can be hard to differentiate among the two. Additionally, Babesia, which is really common in the Northeast and Midwestern portions of the United States, can look like Plasmodium falciparum to some degree. And so trying to differentiate that can be difficult, although we'll go through some pearls for that later on during this webinar. And then finally, because there is overlap in the geographic distribution of Plasmodium species, you can certainly have mixed or dual infection, and that can be very hard to determine if more than one species is present on blood smear alone. So what are the best uses of blood smear microscopy? Certainly, this is still the best method for routine screening, with the thick smear being most sensitive. It can help to determine the infecting species, looking at the thin smear, as well as the degree of infection. And then finally, it's also useful to monitor response to treatment, because we can look to see if the degree of parasitemia is resolving as we are providing therapy. So moving on to rapid malaria antigen detection, there is only one FDA-approved rapid malaria antigen test, and this is the Binax Now Malaria. A lot of you have probably seen this. I have to imagine some of your clinical laboratories use this routinely. This is a little picture of what it looks like. Abbott creates a lot of these. The COVID tests look very similar. But basically, this is an antigen test that can be performed on whole blood, and it looks for two specific Plasmodium antigens. The first is T1, which is a histidine-rich protein, which is specific for Plasmodium falciparum. And so this is highly sensitive, and it has a reported limit of detection of about 0.02% parasitemia. The second antigen, labeled T2, is an aldolase, and this is a pan-malarial antigen, so it's present in all Plasmodium species. This is reported to be slightly less sensitive than the T1, with a limit of detection of about 0.1% parasitemia. And you can see here on the bottom that they show all of the possible testing results. They have an internal control, which just tells you the assay is working. You can see that if you have a non-falciparum Plasmodium infection, you would get a T2 response. Whereas if Plasmodium falciparum is present, you would see potentially just T1 or T1 versus T2, depending on the overall burden. So how well does this assay work? Well, we really only have a lot of good data for Plasmodium falciparum and Plasmodium vivax. This is a table that compares the sensitivity to standard blood smear and degree of parasitemia. And I think the big takeaway here is that for Plasmodium falciparum infection, the assay is quite good. It has an overall sensitivity of 95%, and you can see that it does pick up relatively low parasitemia levels. And so in general, I think this is a good assay for Plasmodium falciparum infection. Unfortunately, it's not quite as good for the non-falciparum Plasmodium species. So here you see the data for Plasmodium vivax. The overall sensitivity is about 69%, and it really does not do quite as good of a job at lower levels of parasitemia. We have less data on the other Plasmodium species, but I will say for those, it also does not appear to be as sensitive as compared for Plasmodium falciparum. So what are the advantages of the Binax now? You know, this is a rapid and easy to perform test and does not require as much expertise for interpretation as smear. I do think it has good sensitivity for Plasmodium falciparum, you know, certainly if someone is sick with moderate or high levels of parasitemia. To some degree, it can help differentiate between Plasmodium falciparum and Babesia, certainly if you have a moderate to high degree of parasitemia. And it can provide some information about mixed infection, although I will say it's certainly not perfect. In terms of the limitations, this does have lower sensitivity than smear, particularly at lower parasitemia levels. It's also got lower sensitivity for the non-falciparum malarial species. As with any test, false positive and false negative results can occur. This will not detect other blood parasites if they are present, so it won't detect Babesia. And it also won't differentiate among the non-falciparum species. And then finally, you know, because this is not a quantitative test, it's not going to give you a degree of parasitemia. And so no matter what, you still have to perform blood smear microscopy. So best uses of this test, I think rapid diagnosis, specifically overnight, if you don't have a trained microscopist to actually review a blood smear, I think this can be helpful. I think it can help in laboratories that don't have a lot of expertise in interpreting smears. Just as an adjunct, it can be useful in that setting. And then finally, there have been times when a smear cannot be safely performed. So this has happened, for example, when we had Ebola outbreaks and there were concerns for returning travelers for Ebola. In this setting, a smear might not be a lab might not be able to safely perform a smear due to concern for potential laboratory transmission. And so this is where a rapid malaria antigen would be useful. So moving on to nucleic acid detection or nucleic acid testing. So this is the direct detection of Plasmodium species DNA. These targets often target the 18S ribosomal RNA gene, which is present in all Plasmodium species. And then through melting curve analysis, you can actually differentiate among the different species, as you can see here on the right. This is performed on whole blood specimens, and it is very sensitive and specific. So this is overall a really good test. I think the main drawback here is that there are no assays that have formal FDA approval. And so these are laboratory developed tests that are really predominantly used by reference laboratories. Some clinical laboratories have developed their own, but for the most part, it's found in reference laboratories. And so access to this in a routine clinical laboratory is more restricted. So what are the advantages of nucleic acid testing? This is also an objective and reproducible result. It is more sensitive than blood smear, and it's also highly specific. So it allows for species determination. And so you can imagine how useful this would be in mixed or dual infections. I think the main limitation is that because it's not an FDA cleared assay, these are mainly limited to reference laboratories. And so a lab would have to send this test out. And so the turnaround time can be longer. And because malaria is a medical emergency, you're going to need to rely on alternative methods for diagnosis early on. This is not a quantitative test, so you still need blood smears to look at the degree of parasitemia to determine response to treatment. Because we're picking up DNA, it can also pick up residual DNA, and so therefore it might remain positive even after the smear is negative. And then finally, it is of higher cost than the other methods that we've already gone through. So I think the best uses here is certainly for confirmation of suspected infection. And I think a lot of states will actually do this automatically, even when they have the blood smear results. And then certainly for species identification, and it's particularly useful with a mixed infection or low parasitemia where you don't have a lot of parasite morphology to really make a species determination. So finally, for the last few minutes, I thought I would just go through some frequently asked questions that I get a lot about malaria diagnostics. And so the first is, if I'm going to make a blood smear for malaria, how many should I make? And should I make both thick and thin smears? And I think the answer is that yes, both thick and thin smears really should be made because there are advantages and limitations to both. The thick is the most sensitive, but the thin can help identify species and also determine degree of infection. And so the standard preparation is to perform 2 thick smears and 2 thin smears. The thick smear actually takes longer to dry, and so people often start with the thin smear because if that's positive, you don't even need to look at the thick smear. However, if those thin smears are negative, the thick smear should be reviewed. How many negative smears are needed to rule out malaria? In general, 3 smears collected at 12-hour intervals. If those are negative, another diagnosis should be considered. This is a general guideline. I will say if you have a high clinical suspicion, certainly we would never say we will only do 3, but this is what the CDC suggests. Can I use a rapid malaria antigen test to rule out malaria? I think the answer here is no. Because of the issues with reduced sensitivity compared to blood smear, a negative antigen test must be confirmed by microscopy. That said, if overnight you don't have that microscopist, you could do serial antigen tests 6 to 12 hours apart to enhance that sensitivity for detection. Can you differentiate Babesia infection from malaria using blood smear? And this is something we commonly get here in New England because of our the endemicity of Babesia species. And I think the answer here is yes, most of the time we can. There are specific morphologic features of Babesia that can help us to distinguish it mainly from Falciparum malaria. So with Babesia species, you often see only ring forms. Extracellular rings are much more common compared to Falciparum malaria. There's the classic Maltese cross that is pathognomonic for Babesia infection. And then the rings of Babesia tend to be more pleomorphic in size and shape than Falciparum malaria. Travel history, of course, is also very useful. My microlab can't make a smear overnight. Can I use the hematology smear for review? And the answer is yes, especially if you need a rapid result. A hematology smear actually uses a slightly different stain known as the Wright stain or the Wright-Giemsa stain. And this stain is not quite as good for intraerythrocytic parasites. So some of the microscopic features will be lost. That said, it's still certainly adequate to look to see if parasites are present and also to get a rough parasite estimate. What we then recommend is that a true Giemsa stain smear be performed when that is available to confirm the results. Blood smear microscopy is not even available overnight. We don't have a hematology smear. What other tests can be performed? And this is where I think the laboratory could consider performing a rapid malaria antigen test. I've certainly gone through the limitations of this test, but I do think it can be life-saving. And again, it's a rapid test that can be done in 15 minutes. Should blood smears be used to monitor response to treatment? The answer here is yes. We recommend blood smears be performed every 12 to 24 hours to monitor response to treatment. And the CDC does recommend documentation of a negative smear at the end of treatment to confirm that the parasite is gone. But should a rapid malaria antigen be used to monitor response to treatment? Here, the answer is no. As I've mentioned, this is not a quantitative test, and so it does not correlate well with the degree of parasitemia. Antigen can also persist after successful treatment. So you might see a positive result even if the patient's infection has been cured. And so this really should not be done. So now I think I will send it back to Dr. Daly, who will go through the case and discuss some further aspects of malaria.
Dr. Daly, you're on mute.
Thanks. Thank you, Dr. Turbett. 2 questions. One, I know the Binax test, the FDA says you must confirm positive or negative. And I was just curious how your hospital system uses it. At Monty, we kind of do both at the same time, a thin, thick, and a Binax now. And I was wondering, I know you work with different hospitals. Do they have different approaches to this?
Yeah, so at MGH, we do have the Binax now test that is available 24/7. And so, you know, if someone comes in overnight and there's concern for malaria, this is something that we can get a result in 15 minutes, which I think is quite useful. There are hematology smears also available overnight, and there's always a hematology technologist that in that setting could also review that if needed. A negative result, we actually do not necessarily follow up with a smear, although I will say that that is exactly what the package insert says, and that is the recommendation. The reason is just that because we get so many, because of the babesia issue around here, it's often in low clinical suspicion. And so we do kind of have a statement that if there's any concern, they need to let us know, and we would do the smear. And it's actually not uncommon for us to do the smear anyway, because that would be our test of choice for babesia. And often in these settings, they're looking for that. So it's really common that both are done anyway. And so I will say that the party line is still that, yes, you should be doing a smear as well to kind of either confirm the results, or if you have a negative result, just because of the issues with sensitivity.
Great. I just will say two more things about microscopy. One is your point that you need to show a negative smear. We had a case in the Bronx where we did do smears every day, discharged the patient, and they came back with malaria 10 days later. And in retrospect, their discharge smear was still positive, and we should have reacted to that. That was a signal that they had partial resistance. The other time that we've gotten slightly burned is that the technologist sees gametocytes on the smear, and it may make the clinician think they're failing therapy. So they have to be able to distinguish gametocytes from trophozoites. Gametocytes, if they're there, that has really nothing to do with the clinical illness, but I've also seen where it's a positive smear reported, although they're gametocytes, and the clinician continues to treat. Is your team able to, do they discriminate? Okay, these are gametocytes, it's okay. How do you manage that issue?
Yeah, so the way we would look at a smear is we would really only count infected red blood cells. And in the case of falciparum, you know, that would be the trophozoite form. So we don't actually count gametocytes in our parasitemia. We might say they're present, you know, we might say rare gametocyte or something like that. But for the most part, it's looking at what is present in the red blood cell only.
Terrific. All right, so back to our case. Her RDT is positive for both falciparum and a second species. And Dr. Turbot went over what that looks like. We always have a positive control, and she has a mixed infection. Next slide. And so this gives us just a quick overview of surveillance. This is the latest data from the CDC. It's a problem. I mean, you can see this is 5 years old. But the bottom line is we have about 2,000 cases of malaria in the United States, basically all in returning travelers. And I like to point out that it's in almost every state. So healthcare providers have to be ready for malaria no matter where they work. We certainly see a fair amount here on the East Coast. Most of these patients are visiting friends and relatives. So whenever we're seeing somebody with fever who's an immigrant from Africa, it should be in our mind. We can see that every year we have a couple of deaths. We had 7 deaths in 2018. Most of them are falciparum, and occasionally there is a Vivax case. Now you can see most travelers have falciparum, and remember, 90% of the world's malaria is falciparum. So this is sort of just replicating global epidemiology. Falciparum by far is the most common. As Dr. Turbot said, this is sort of the fatal one and the one that's drug resistant. And a lot of our travelers have this history of no chemoprophylaxis, just like our patient, and 85% acquire malaria in Africa. Next slide. Just wanted to remind us of the malaria life cycle. It starts with the Anopheles female mosquito. She takes a bite. She sends only maybe 8 sporozoites, which is the target of the vaccines, to the liver. And over 2 weeks, in the case of falciparum, they expand exponentially. And this is a silent stage. We cannot really detect who has these. And then the illness stage really is occurring as they're emerging from the liver, releasing myrizoites, which are foreign antigens. We have cytokine response. They're infecting red cells. They're going from 1 to maybe 30. So very quickly, you can generate a very high parasitemia. Small percent become sexual forms, and they're taken up by another mosquito. And I like this because when I'm thinking about advising my patients, we can talk about avoiding the vectors and we can talk about chemoprophylaxis to prevent symptoms from the blood cell stage. Next slide. Every single patient I see, especially falciparum, but with the others as well, we review severe disease criteria because this is the problem. It can be silent. So there are clinical manifestations. Our patient didn't have any of these, but there also can be laboratory tests that point to severe disease. So every time we see a case, we actually go through this list. And again, there's some lab criteria. If they fall into any of these criteria, we're going to have to change our therapy. It's going to be IV artesunate. So I think it's worthwhile looking at this and then watching the patient overnight. If they develop any of these symptoms or lab abnormalities, we now have to put them in the category of severe disease and change our therapy. Next slide. So what's treatment for falciparum? It's pretty straightforward. It's combination therapy. We've learned our lesson like the people in TB and HIV. Let's use combination therapy for stall resistance. And in this country, we have coartem, artemether lumefantrine. We can also use malarone, atovaquone, proguanil. Quinine's not available. And be very careful when you're writing for chloroquine. Most falciparum is resistant. Places like the DR, Haiti, Middle East, and parts of Latin America are chloroquine sensitive, but just be sure you look it up to be absolutely sure we're not undertreating chloroquine resistant falciparum. Now, in our case, we have a second species of Vivax, and we now have to treat the liver stage as well. I was telling Dr. Turbot in New York State, of course, every state malaria is reportable. New York State, they will let us know if there's a second species, because honestly, unless we have Dr. Turbot in the room, it's really hard to speciate sometimes. So that really helps us to know. And again, our antigen test found Vivax, but often Vivax and Ovale have such low parasitemia, you may not see it. So we do have PCR as backup. Next slide. So what happened to her was, she had mild malaria, did well, but her blood pressure decreased to 70/50 and unable to take PO. And if again, we go back to our severe disease criteria, she now has severe disease. So we're going to go to the next slide. And this is one place where I've seen a couple of, at least 2 malpractice cases where the patient is appropriately defined as mild malaria, and then they deteriorate overnight. So I think for us ID folks or people who manage this, we should say, let's observe closely over the next 24 to 48. If they develop criteria, we have to go to artesunate. It is the drug of choice for severe malaria. Quinidine is no longer available in the United States. The cardiologists have gotten rid of that drug. So this has been an issue. How do we get artesunate? We used to have to call the CDC and they would fly it in, but the good news is it's now commercially available. So I think every hospital healthcare system has to figure out what to do because it's $30,000. So do you stock it, waiting for those cases? Do you share with other hospitals in your region? And there are programs that can share and help you with consignment. FFF Enterprises, for example, is someone we work with in New York. So if we need it last minute, they can get it to us. By the way, the CDC will still supply it if you can't get it within 24 hours, but we should all be able to get it commercially. If we don't have artesunate ready, go ahead and give some oral antimalarials, maybe antiemetics, get some drug on board, and then follow with artesunate. One thing to know about artesunate is it's a great drug, but you can get a delayed hemolytic picture. So we have to keep an eye on whether they develop hemolytic anemia for 4 weeks after. Next slide. Great, so she recovered, confirmed to have Ovale, and the rule is we still give her a full course of artemether lumefantrine. You don't subtract days because she got IV artesunate. So give her IV artesunate. We give it twice a day until parasitemia is less than 1%. And then we still give a full course of artemether lumefantrine. She took that, that's terrific, but we now have to deal with the hypnozoite of Ovale. So I'll just give you guys 1 second to think about how we're going to deal with this. And then we'll go to the next slide. So the problem is standard antimalarials, artesunates, all of them do not kill hypnozoites. And Ovale and Vivax have this additional stage that kind of stays in the liver silently and can reemerge months to years later. We need to eradicate that. That is called a radical cure. And next slide, how are we going to do that? We're going to have to use this new class of antimalarials, the 8-aminoquinolines. Next slide. So traditionally, we've used primaquine, which was FDA approved a long time ago. It's going to do a radical cure for your patients with Ovale or Vivax. In endemic areas, we're trying to get rid of gametocytes, so we give a dose, and it can be used for prophylaxis. The problem with primaquine is we can't use it necessarily in G6PD. We can't use it in children or pregnancy lactation because we don't know the baby status. The problem is you have to convince your patient to take this pill once a day for 2 weeks after you cure them. But there's been a new drug, tafenoquine, next slide, which was FDA approved a few years ago, and it does the same thing, and it's a single dose, and this is a major breakthrough. Next slide. So in this case, once the patient recovers, we treated the active phase of infection of Ovale, we're now either going to give her a single dose of tafenoquine if she's G6PD normal, or 2 weeks of primaquine. So you say, well, which one should I give? You can only use tafenoquine if you treated her active infection with chloroquine. In this case, we didn't. In this case, we gave her AL because she also had falciparum. For some reason, tafenoquine will not be effective. So we're kind of stuck with 2 weeks of primaquine for her. But other patients who have pure Vivax or Ovale, chloroquine is still the drug of choice, except for a few exceptions. They're G6PD normal, single dose of tafenoquine. It's a great breakthrough. We're still having problems easily getting this. It's not quite in the market. We have to really seek it out. But I feel like it's the setting of Malarone 15 years ago when Malarone just came out. It took a while for us to become comfortable with it and for pharmacies to be stocked. Next slide. I just wanted to give one update about P-Vivax. We were all taught that Vivax is benign. It only infects reticulocytes. It doesn't make us ill. But we've always seen a couple of cases of death. We never really understood it. And as it turns out in autopsy studies, if you take the spleen, there are viable Vivax both in the spleen and in the bone marrow. So there's more and more data that there are these extra vascular sites of P-Vivax. And in fact, they probably have a much higher biomass than what we see in the peripheral smear. So I just want to remind people that Vivax can also cause severe disease and lethality. And this is some breakthroughs in pathogenesis. Next slide. So in terms of preventative therapy, and we talked about 85% of travelers who get malaria and return to the US haven't taken chemoprophylaxis. So we have to do better. I think a lot of it's access. And Dr. Turbot, I'll be interested in how you do this, but go to the CDC, we look at which country, what part of the country has malaria, because it's very region specific. It'll tell us whether chloroquine will be effective. We can see in India it is not. We can see what species are there and recommended chemoprophylaxis. Next slide. And so when I think about prophylaxis, I think of a couple things. I really think about how frequently it's dosed, what the patient prefers, and what the side effect profile is. So look, I love mefloquine. It's once a week. We have to use it for 4 weeks upon return because, as Dr. Turbot said, actually a falciparum tends to make you ill within 30 days. And that's why we use this post-return for 4 weeks. It's to capture them. This is called causal prophylaxis. Now, this is contraindicated with neuropsychiatric issues. I also love atovaquone proguanil, but it's daily and it's a little bit expensive. But notice we only have to take it for a week post-travel because it has some efficacy on the liver stage. Doxycycline is a great drug, but it's daily. We need to take it for 30 days upon return, but it's not very expensive. Next slide. The other way to go is with these 8-aminoquinolines because they're actually going to get the liver stage, so you won't even have a blood stage infection, tafenoquine is great. It's going to be weekly and again, post-travel. We have to make sure our patients are G6PD normal. And my feeling is tafenoquine is really probably going to be used more for prophylaxis, maybe than for radical cure. But let's see as this becomes more available and where you practice, how much we're using the tafenoquine. Next slide. So just to make our lives more complicated, there are two formulations of tafenoquine: radical cure, Crintafel. So after we cure Vivax or Avale, we come in with single dose Crintafel, 2 tablets, 300 milligrams, or Aracoda. And again, we showed you how to dose it. You could probably substitute them for each other. They're exactly the same. Next slide. Just wanted a few points to update folks is that we are unfortunately starting to see some resistance to coartem in Africa. And if you look at this figure, we can see patients that are still positive on day 3 of artemether-lumefantrine. And remember, Dr. Turbot talked about it, we should really be looking at a negative smear by day 3. If not, it's an indication that you may have partial resistance. And we can see that it's emerging 2016 to 2019s in regions of Eritrea. Next slide. The good news is we have molecular markers of this resistance. So mutations within this parasite gene, PF-Kelch13. So we can actually monitor this in the field, and that's good news. But like I said, we just had a case in the Bronx. If we have these cases, CDC says maybe extend the therapy or change the class. But honestly, I would call the CDC. They, by the way, can take these parasites and sequence them for you as well. So I would call the CDC if you're concerned that you have partial AL resistance. Next slide. Last few comments on autophonous malaria. We all heard about these cases in the summer. Most of them were Vivax. Thank goodness there was no deaths. And there was a case in Maryland of falciparum. And autophonous malaria means that that person didn't travel, didn't acquire it from a blood transfusion. It was truly local cases. And probably what happened was there's someone else in the community with malaria, and a mosquito, which can only fly a mile, infected these other folks. Next slide. I wanted to tell you just a little bit about the Maryland case, because it's really interesting. So this was August 6th, a resident in the National Capital Region. Typical non-specific symptoms, fever, malaise, myalgia, absolutely no travel. Notice that they went outside a lot and walked around. And if we look at the labs, there's that anemia, there's the low platelets, hyperbilirubinemia, and they saw intraerythrocytic parasites. Next slide. So they weren't thinking about autophonous malaria, and they called the CDC, which is what we should all do. So CDC took a look at the smear, and they couldn't be sure. So as Dr. Turbot said, we can't really tell the difference. The patient was actually treated for babesia and got better because, atovaquone absolutely has some plasmodium effect, azithro and doxley. So patient got better, reduction in parasites. They felt very happy with their diagnosis. And then August 15th, via PCR, because they also routinely do this, they said, uh-oh, that was actually falciparum. And they brought the patient back and retreated with AL. So it's sort of a good connection to, the issues up in New England where you're seeing a lot of babesia. It's really hard to distinguish. So you have to keep this in mind. Next slide. So when should I consider locally transmitted malaria? Well, the CDC says anybody who has an unexplained cause of fever, which is a big lift. For me, I get maybe more excited if there's a hemolytic anemia. I love to see the thrombocytopenia. And I guess if there's obvious cases in your neck of the woods, you may think of it as well. So maybe, and I'm sure Dr. Turbot is like horrified by this, but she's going to get a million more slides. But, we used to have malaria endemic in this country. It's possible. We just have to keep this in our mind. And the next slide. Okay, CDC, they are rock stars. They are available 24/7. I call them all the time. They can do drug-resistant genotyping. They can help you with clinical questions. And I think that is our last slide.
Thanks so much, Dr. Daly and Dr. Turbot. That was fantastic. We all know a lot about malaria, but it's so important that I think every time we hear somebody talk, especially experts like you, we gain something that's important, and it's important, right? Because patients die of malaria. So thanks again. Let me ask some questions from the chat. This one's for Dr. Turbot. So the question is about the rapid malaria diagnostic testing. I think this is relevant because, the CDC has identified that most deaths from malaria in this country are due to delayed diagnosis and delayed treatment. What are the limitations to widening availability of Binax?
It's a great question. So the Binax test has actually been around for a long time. It's a moderate complexity test under CLIA, which means that it has to be done by certain trained individuals and in clinical laboratories where there's proficiency testing, competency, things like that. That said, it doesn't mean that this is a test that has to be done at a high complexity lab, but you do need to have, it has to be under a CLIA certificate. So there's first, I think that issue is that it can't just be done, unfortunately, from a regulatory standpoint by a nurse who sees a patient and then says, "Oh, I'm concerned for malaria. Let me just grab some blood and then go do this." It does have to be more regulated than that. So there's just that logistical component. And, it's something where if this test were CLIA waived, for example, similar to kind of the Binax COVID tests, you could imagine that being done right at the point of care, at the bedside, or something like that. So I think there's that first issue. And then I think the other issue is just that, in the United States, malaria is just not that common. And so it's hard to actually verify these tests, simply because in order to verify a test, you need cases to determine that your test is accurate. And so if you only see one malaria case a year, that could be quite challenging. And so this is where, we in the Northeast are really trying to encourage and help other clinical laboratories in our hospital systems to stand up rapid malaria testing by providing samples and things like that, just because we seem to have a larger catchment of cases of malaria. Sometimes the companies can help. So, you can always reach out to Abbott, which makes the Binax now, to see if they have samples. The CDC is also a resource where they might have samples. And so speaking with them as well, because I do think there is a desire to increase the availability of this testing, across the United States.
Thanks so much, Dr. Turbot. Dr. Daly, let me switch to you. So we talked a lot about initial testing and treatment. How does whether you have a positive result on the rapid antigen test versus the smear dictate your choice of initial antimalarial therapy, or is it all about how the patient looks clinically and if they have severe disease?
Thanks for that. It's looking at those clinical findings. If they fulfill any of that, we're going to IV artesunate. And we do have to wait for that thin smear for that parasitemia. Non-immunes, we sort of use a 5% parasitemia or greater as severe disease. In the field, we use a 10% greater. So I think the clinical picture, the laboratories, and then that parasite load. I guess if we got the parasitemia the next day and they were 6%, but there looks like they're responding well, then I wouldn't necessarily give IV artesunate.
Thanks. I'll look in the chat in just a minute, but I've been struck by good news lately with malaria. Let me ask you, Dr. Daly, we now have multiple vaccines for malaria. What as an expert, what's your view of the current landscape and what's ahead?
Absolutely. So this vaccine has been like 40 years in development, and I always think about that compared to SARS-CoV-2. So the first vaccine, RTSS, targets the sporozoite, 40% effective. Okay, not great. WHO had to really struggle with saying we're going to approve this or not, and they did because it's so many people. It probably makes sense. This new vaccine, R21 matrix, targets the exact same area of the sporozoite. The difference is that it uses a much simpler adjuvant saponin. So even though that first paper said 75% efficacy, probably if they test it in high transmission regions, it will also be about 40, 50%. But the benefit is they can probably make hundreds of millions of doses of R21 matrix because the adjuvant is so much easier. So I think Serum India said we can make 100 million doses. The problem with RTSS is because it's so complicated, maybe they can only make 10 million. So I think the good news is we're going to be able to have a lot more doses delivered, and it's, 40%. So we're still going to have to do bed nets, have therapies. So I would have been much happier if the vaccine was 80, 90%, but we're not quite there. But at least maybe we'll have more to distribute.
Yeah, it's great to have something. Do you ever see this being a vaccine that travelers from the United States might take before they go to endemic regions?
No, because it's never been really tested in non-immune. And secondly, the efficacy is so low. So I think we still need chemoprophylaxis. We just have to be convincing to our patients to take it the entire time and take it for the return piece. I don't see any big changes on that aspect. I think it's still going to be the drugs that we talked about.
That makes sense. And let me ask, so during COVID-19, I think we've all become familiar with monoclonal antibodies, both for, treatment and prevention of COVID-19, and now a new monoclonal to prevent RSV in babies. What do things look like in the malaria sphere with monoclonals?
Yes, I mean, monoclonal antibodies are now $1 billion industry in all diseases that we all see across different specialties. So we're now looking at that in malaria, and it looks like there are monoclonals that, again, target the sporozoite, and they look very efficacious. And there's a couple of really interesting features about it. One is that they modify the monoclonal, so it has a very long half-life. So it's possible that a single monoclonal injection will protect these children across, let's say, a 6-month transmission season. And the other thing is that you can give it subcutaneously, which is very important. There's no way we could give an IV monoclonal antibody in large numbers. So the question is, will this be produced? Will we really execute on making the monoclonal? Can we get the price tag down? But I think this is a possibility. It gives a guaranteed blood level of antibodies. It doesn't rely on your immune response. The downside is that we'd have to give it every year. There's no memory developed. It's not a classic vaccine. So I think it's exciting, but I want to see if anyone's going to start producing it and really rolling it out.
Yeah, unfortunately, it seems like that's always the challenge in resource-limited settings. Dr. Turbot, let me ask you sort of a hard question. If a hospital treating a patient with malaria didn't have quick turnaround time to smears, how do they manage that patient? What if the smears are send-outs, but the patient is improving?
Yeah.
How do you decide when to discharge the patient?
I think that's really hard. And I think this is where if it's a patient that's already been diagnosed and they're getting treatment, this is where the clinical parameters are going to be really important, right? Is the patient still having a lot of hemolysis? What is their renal function doing? Do they have thrombocytopenia? Have their fevers resolved? All of these things. I think this is where you have to use your clinical judgment. And then I think also just really ensure close follow-up, right? Not all malaria has to be treated in the hospital, right? And in fact, not all of it is. But you then have to be able to monitor patients, right? So I think that's where I would be using a lot of my clinical parameters, the other basic laboratory parameters to help make those decisions. You should also have hematology smears, which I know aren't perfect by any means, but it's better than nothing.
Yeah, I think that that is a great pearl. Having the hematology smears can at least reveal a high amount of parasitemia. Dr. Daly, let me ask, are there any special treatment considerations for pregnant women?
Thanks for that question. 2 years ago, we were not using artemether lumefantrine to treat women in their first trimester. WHO has changed that, so has the CDC. So we can now use artemether lumefantrine in any trimester for pregnant women. So that's one new thing, and that's great. And the other thing is, of course, IVR tesonate, we should absolutely use in pregnant women. We shouldn't be worried about that. So I would say, except for the prophylaxis, that's where I look at pregnancy and maybe look more carefully at what's contraindicated for prevention of malaria. But for treatment, we can use the same protocols. For prevention, we have to be a little more cautious about which antimalarials we use. There's still some guidelines that if you're pregnant, you shouldn't travel. And I think that's, you know, a reasonable thing. But if you have to travel, there's still some options for prevention.
Thanks. Dr. Turbot, you know, you and I see this a lot, but maybe if you could just give 20 or 30 seconds to remind us what are some other parasites that we might see on a blood smear in somebody who we're testing for Babesia. Yeah.
Also, certainly Babesia, that's around here all we think about that a lot. That's the classic erythrocytic parasite of the Northeast and Midwestern parts of the United States. Certainly the Plasmodium species, trypanosomes can sometimes be seen. You know, so those are really the big ones. Granted, a lot of that will require expertise, right? Particularly for, you know, trypanosoma or things like that. And so that's where having really experienced microscopists and parasitologists can be helpful. You know, I'm very lucky in that we have those. Not all clinical laboratories do. And so to kind of Dr. Daly's point, this is also where I think molecular methods like PCR have really come into play. Just because it takes out that experience and expertise component. These are more automated, objective assays. And so I'm hoping that eventually these all they become more available, right? So that clinical laboratories can implement them. But obviously from a regulatory standpoint, that's complicated.
Yeah, wouldn't it be lovely just if a parasite is seen on the hematology smear, it could reflex to a intraerythrocytic parasite PCR panel. We can
I mean, you know, the goal hopefully is, you know, I will say at MGH, we're hoping to eventually get to that point where we would, yes, do, you know, molecular based testing, but because these are not FDA approved, even there is no PCR for Babesia either, right? So that's FDA approved. And so this does require laboratories to develop these tests, which is more labor intensive, requires more validation. And then, you know, the current milieu for regulation of laboratory tests is also very much in flux.
Yeah. Well, it looks like we are at the end of the hour. I want to just again thank Dr. Daly and Dr. Turbot for their expertise. We have learned a lot about the diagnosis and management of people with malaria, a really important topic since this is a potentially deadly infection. Make sure to text your CME code. And as we said, this will be recorded and on the website. Thanks, everybody.
Thank you, Jake. Bye-bye.